There's a list of, so there's L&D drugs, there's postpartum drugs, and there's newborn drugs. So you need to be very cautious because you have Pitocin for labor and delivery and you have Pitocin for postpartum. We use Pitocin a little bit differently in labor and delivery than how we use Pitocin postpartum. Alrighty, well that's easy. Ooh, one thing off the list. So if you have questions about clinical, the other thing is tomorrow, I think it would be really helpful that if you're struggling finding something on that particular worksheet, rather than Googling it, it may be helpful to perhaps check with the faculty member and I can guide you where to find that information. You may be thinking it's something really complicated when it's actually something really easy. Some of the things are not in the assigned chapters. So for example, if you're looking for lab values on a newborn, you're going to have to look in some different places to get that. Okay, so some of it's wording and that sort of thing. But I'm happy to help you kind of decipher things. So it's not meant to be a challenging endeavor. It's meant to give you kind of that basic fundamental knowledge so you at least have some idea what's going on in clinical. I think the worksheets are very helpful study tools, but not for the first exam. Okay. So what do I mean by that? In about a month or so, when you need to study for exam 2, I would print out a blank L&D worksheet, see if you can fill how much you can fill out from what you remember, compare the new one to the old one, and see where the gaps are, and that's the only stuff you study. Today we're going to finish conception. I have a present for you. So we're going to play with present, and then we're going to start physical and psychological changes of pregnancy. And we probably won't finish that today. Tomorrow we'll finish physical and psychological changes and do antepartum nursing assessment. Both today and tomorrow are critical. We're going to have examples of test questions that you can anticipate for the exam. So we have some short answer type of questions, and we'll do things like calculate due dates and do gravital care. Before I start, any questions from Tuesday? So long ago. Feels like it was 2 weeks ago, but it was really just 2 days ago. Straightforward. The other thing I would recommend is, again, I'm pretty intentional in my cadence, so you notice I'm going to go pretty fast here through this beginning things. So again, you're not going to have 25 questions from the conception chapter. You're going to see again that I slow down some of the tests in pregnancy at risk. All right, so we talk about identical and fraternal twins. Is anybody a twin or triplet? No, interesting. Usually I have somebody. So can you have an identical male and female baby twins? Can you have male-female twins that are identical? No, because the girl is XX and the boy is XY, okay? So you cannot have an identical male and female. So if they're identical twins, fertilization occurred, you had the matching of the chromosomes, and then another extra replication occurred. So it's like they joined together, and then there was an extra one, and they kind of developed there at the same time. Versus fraternal twins, you could have a girl and a boy, or a girl, because again, it's two different ovum, two different sperm. Okay. Please do not stress about whether it is one chorion, one amnion. It talks about in the text. Our nursing care does not change based on the number of chorions. Okay. So that while it is, we see it on ultrasound and things, and there may be, again, certain risks associated with that. Again, we're watching for potential complications, but twins run in families. So if you're getting a history from a patient and she says that there's multiples in her family history, we're going to do some early diagnostic testing on her to see whether, because again, it's the early pickup of a multiple pregnancy. Here in our area, in Louisville, when you talk with the nurses, again, I think they're pretty kind of nonchalant about multiples. We see multiples a fair amount. The other thing is we see they occur naturally, but also from infertility, so fertility treatment. However, when you have a multiple gestation, it increases risk for both moms and babies. So it's not just, oh, it's cute, oh gosh, I only have to get pregnant once, so I can have 2 babies and be done. It is risky for both parties, okay? Now, looking up at this picture, you can see here, so see how you have this is the baby, kind of looks like a little alien. This is the umbilical cord. This is the bag of water around. So each baby has its own bag of water, okay? And so you can have one of the twins can rupture. You can also see if there's cord compression or poor circulation at whatever site that one of the twins is in, that can cause a complication. So you can have one twin die, but the other twin can continue in pregnancy. The problem when a twin dies is that can increase the risk then of premature delivery of the other twin and infection in mom. And if mom gets septic, we have to deliver the babies. All right, this is not in your book. I just think it's cool because I like kind of need to know graphics. So this is just review for you from autosomal dominant, autosomal recessive, and I've picked X-linked recessive just because it's more common. There are certainly many other modes of inheritance, okay, and you remember that from biology and pathophysiology and A&P. But just to hit some of the key ones that we talk about in OB, this is where we're getting a family history. So if mom or dad have this in their history, then we might do some earlier genetic screening with parents. So with autosomal dominant, probably one of the key diseases that we'll see is called Huntington's chorea. It's a neuromuscular disorder. And then also there's certain types of muscular dystrophy that are also genetically transmitted. With autosomal recessive, probably the most common one that you're familiar with is sickle cell anemia, but then there's also cystic fibrosis. We see more sickle cell anemia in African Americans. We see more cystic fibrosis in Caucasian patients. That said, you can be a carrier, and so you don't know that you're a carrier. You don't exhibit any symptoms of disease, and so that's why a lot of times those screenings are offered to women. Now, one of the big concerns about autosomal recessive, though, is if you're a carrier and your partner's a carrier, okay? So you guys remember Punnett squares, and you had to go and figure out what the percentage was about if you're a carrier and a carrier. Whoops, that's okay. So if both parents are carriers, what percentage has a risk of disease of their offspring? This is how I do it. Right? Does that ring a bell? So 25% have disease. Yeah, okay. And then you have carriers, and then somebody who's not affected. So. And then X-linked recessive hemophilia is probably the most common one there, color blindness. And so if you have an X-linked recessive trait, you're going to see that expressed more in male patients because there's nothing opposing the X chromosome that has the defect. Okay. So trisomies. Trisomies are getting a lot more public press now. When you hear about Down syndrome, there's kind of a movement now to call it by its name, trisomy 21. And so trisomy means that there's three. You should only have a pair, so you have an extra chromosome, and it happens to be on the 21st pair. There are certainly other trisomies, trisomy 13, trisomy 18, but trisomy 21 is more common. And again, this is not in the textbook, but I think it gives some kind of thinking about therapeutic communication with patients and their kids in terms of Down syndrome. So we would never want to say that he has Downs. People have Down syndrome, they don't suffer from Down syndrome, so word choice is really important. We never say the words mentally retarded anymore. I think that everybody's pretty comfortable with that now. But I think you have to remember, while we may not use it, patients and family members may use those words. So we kind of have to help parents reframe their thinking. So let's say you're the nurse, and you just had a confirmation that the baby has trisomy 21, and so mom is pregnant, and so the mom asks you the question, is my baby going to be retarded? So how would you answer that question? Be brave.
Let me have like a different way of saying it. Basically like politely.
Politely.
He's gonna especially when she's growing up or
Learning deficits.
Well, and some of it is we don't know. Again, there's So I think that's the other thing is, we don't know for sure what the level of functioning will be. But certainly the baby is at risk for having some health issues, maybe at risk for having cognitive difficulties. But I think, again, it's a very difficult thing to say. And when you hear those words, it's kind of like, oh, I don't really know. And I think as you work with patients, it's one of those things, it's not like people plan to have babies that have genetic defects. They happen. And so parents are often like, is it something I did? Did I do something wrong? Oh, it's because, I drank when I was early pregnant or something like that. We can't do any blaming, because remember, that all occurred at conception. So there is no kind of turning back time and fixing the extra duplication of the chromosome. So there's nothing that after fertilization that you can kind of do to undo that. But I think the other thing is thinking about when you're diagnosed. Is it early? Is it later? Is it first trimester? Is it second trimester? What do you want to do with the pregnancy? So it used to be, we used to have a lot of women who actually terminated their pregnancies for babies with Downs. And so now that's an ethical dilemma. A lot of people see that as murder, and they see that as being very an inappropriate action by a parent, particularly after second trimester. So that now, because of how much better we are in terms of our care of fragile infants in NICU and things, that also now is seen in trisomy 18s and trisomy 13. So again, long time ago, when babies had trisomy 13 and trisomy 18, those babies often died in utero. They died at birth because we just didn't have the means to take care of them. But now you're seeing babies with those trisomies actually live months and years. And there's, again, support groups for women who have babies with trisomy 13 and trisomy 18. So I think, again, you're going to see that change as we get better at taking care of children, especially children with fragile needs. Okay, so it's not just Down syndrome. There's certainly other genetic defects. Even the word genetic defect, we're supposed to say genetic disease. Okay. All right, so there's two pictures on this slide. This one on the right is from the book. This one on the left is not from the book. I always like to point out things that I don't really care for, and one of the things that I don't care for in our book is the chart that lists the germ cell layers. I like this better because I feel like it cuts to the point, okay? So there's a really long list, and this is in a table, and it's kind of dry and boring, and I like this because it has pretty pictures, and it talks about the 3 germ cell layers. So you have endoderm, mesoderm, ectoderm. Ecto's on the outside, meso's in the middle, endo's on the inside. And so from the inside, that germ cell layer helps in the formation of these organs. So remember that all of these germ cell layers, again, are critical in the formation of these organs. And so if there's some type of error or harm to a particular germ cell layer, we usually see a defect in all the structures that arise from that germ cell layer. So for example, let's look at the mesoderm layer. If you have a baby, let's say again, there was some type of error in terms of early development, and the baby has a heart problem, then we can also see problems with the lungs and the spine. Okay, so we see those things kind of grouped together. So again, there's 3 germ cell layers, different organs arise, so it's not like immediately the baby has a pancreas. It takes some weeks for that to grow and develop, and all of this development is occurring typically in the first 12 weeks, okay? Now I say 12 weeks, the book says 10 weeks, and the difference is I'm talking from last menstrual period. Because remember, last menstrual period, I'm not pregnant for 2 weeks because I had ovulation mid-cycle, and that's when fertilization took place. So if you see a 2-week discrepancy between what I say or what the book says, it may be, are we counting from last menstrual period or are we counting from the date of conception? Typically, OB nurses, we count from last menstrual period. All right, so now on the right-hand side, this is again looking at an embryo in the first trimester. So the first trimester is approximately the first 12 weeks. And so with this, you can see it looks like a little alien. So here's the head, here's the tail, there's little arm buds, looks like a little T-Rex, okay? You have an umbilical cord here, And notice again, there's this tiny little bag of water. There's really only about 30 milliliters in the bag of water at this point. So not enough to do amniocentesis. Because if you took off fluid, then the membranes would collapse on the embryo and it would hurt the baby, okay? Now, the structures around this are gonna help in terms of the formation of the placenta, okay? And so you'll see right here, see where it talks about the chorionic villi, okay? That's very rich, very vascular here, okay? So a very early genetic test that can be done is chorionic villi sampling. So they actually will go in and take a little part of that membrane and they can get genetic information from that. But certainly that's an invasive procedure. It poses risk to the developing embryo. Now, there's other types of testing. It just depends on how much detail you want in terms of your testing. We have early blood testing now that we can do with mom because we can actually see in mom's blood some fetal DNA that kind of cues us in if there is a problem. So we tend to start with the most non-invasive thing first and then work our way up toward invasive, which is similar with most healthcare things. You start with the easiest thing first, okay? So you may have heard some conversation about the amnion and the chorion, okay? So when you talked about the placenta, you talked about the maternal side and the fetal side. So it's Shiny Schultz, Dirty Duncan, you might, and so when you're at clinical, I do think it's helpful to kind of look at the placenta, kind of see what it looks like. It's really interesting. I think the other thing to remember is it takes time for the placenta to develop, just like it takes time for the embryo to develop. So the placenta doesn't become kind of its own entity until usually after the first trimester. So talking about amniotic fluid, that's kind of the hot tub that we were talking about, the baby being in during pregnancy. Amniotic fluid is a good thing as long as it's in balance. So too little is bad, too much is bad. It needs to be just right. And what it does is it keeps the environment just right. It's a constant, comfortable, moist, even temperature environment. But certainly if mom's temperature is raised in the presence of infection, that changes the intrauterine environment for the baby. If mom's circulation is impacted so that there's not good circulation to the baby, you'll see a change in the production of amniotic fluid. Now, in amniotic fluid, I'm going to go back to this picture just to kind of, again, get you thinking about this conceptually. Remember that in utero, the baby does not breathe air. Okay, the lungs are filled with fluid. So yes, the baby is peeing in the same fluid that goes through the lungs, but we consider it all sterile. It's all very good. There's not anything to worry about there, as long as it's the right amount of fluid and there's nothing funky in the fluid, like infection, or let's say meconium, which is this green, tarry, nasty stuff, then that might pose some problems for my baby, okay? We generally don't see meconium until at the very end of pregnancy, when mom's in labor, so it's not like meconium's hanging out in there for like 20 weeks or anything like that, okay? On ultrasound, we can measure the amniotic fluid to make sure that there's adequate amniotic fluid, but we also want to make sure that the amniotic fluid is cushioning the baby from any kind of trauma. So the trauma could be a motor vehicle accident, the trauma could be a fall, you slip on ice and snow, but the trauma could actually be contractions, because when you contract, when you're in labor, it puts more pressure on things. Now we want that to happen, but if I cut your lifeline, which is the umbilical cord, hopefully you have reserve to deal with that. So when the contraction lets up, it's like, oh, thank you, oxygen, yay, right? But if I have a really long, hard contraction, or I don't have very many breaks, my baby says, I'm a little tired, could I help? And that's when you start to see decelerations in the baby's heart rate, okay? The amniotic fluid also allows our baby to move and grow symmetrically, okay? So it's really nice. Babies can kind of turn cartwheels, they turn around, they move, and so that movement's gonna help their extremities develop equally. If for whatever reason there's not a lot of amniotic fluid and I kind of get stuck up against one side, well, this little arm bud doesn't get to move and grow, and so you'll have stunted growth, and that's called amniotic band syndrome, okay? So we need to make sure the baby's growing and developing. We have adequate amniotic fluid. We're looking at the cord to make sure there's no problems there. It's an old wives' tale that certain activity causes a knot in the cord. Okay, that's not true. Some people have long umbilical cords, some people have short umbilical cords. Some people have fat umbilical cords with a lot of that Wharton's jelly. Some people have skinny umbilical cords. Now, when we look at amniotic fluid, and I need you to tune in, this is an important concept. Easily confused, students get this mixed up, okay? So there's 2 times that we generally do an amniocentesis to look at amniotic fluid. If I'm concerned about a genetic diagnosis, I'm going to do that around 16 to 20 weeks. That's different than what you see on the slide, where it's talking about lung maturity. We do an amniocentesis for lung maturity of the baby around 36 to 38 weeks gestation, okay? So I would not do an amnio at 37 weeks to try and see if the baby has Down syndrome. That would not be appropriate. I would not do an amniocentesis at 16 weeks to see if the lungs are mature, because I know they're not. The baby's not old enough to breathe on his own, okay? Now, with amniocentesis, when I'm looking at lung maturity, that can help guide me in terms of making decisions for this particular patient. So let's say that the patient has health conditions, and I'm not sure, I'm concerned about the baby, but I'm also concerned about mom. So the physician may do an amniocentesis saying, I see the presence of PG and my LS ratio is fine, and that tells me, yep, the baby will do well. But if the presence of PG, which again is phosphoglyco, blah, 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 if that is not there, they may still go forward with delivery, but they're just gonna notify the NICU team that this baby may need more resuscitation because there's not surfactant present to be able to keep the lungs open, and the baby may need more assistance in terms of breathing, okay? We're really changing what we do in practice, so I think you're gonna see some variability. For example, we used to do a lot of amnios at 36 weeks if the lungs were mature. We'd do a C-section at 37 or 38 weeks, and it just keeps bumping up and up and up. So some of the facilities that you folks have clinicals at, they cannot schedule C-sections before 39 weeks. And so again, it's because of that risk of lung maturity, because even if the amnio shows mature, we're finding that a lot of times those babies are having difficulty with temperature regulation, infection control, and so it's better if we can just wait until after 39 weeks in terms of delivery. Also, let me go back to amniocentesis. We'll talk about this when we do assessment of fetal well-being. We do not do that as registered nurses. That's performed by a physician. There's usually another person doing, assistant doing an ultrasound. So somebody has an ultrasound. The physician's taking a needle in, drawing off just a little bit of fluid. The fluid should be clear, straw colored. There really shouldn't be anything present in it. Now they do the same type of procedure at 16 to 18 weeks. They take off less fluid because they don't need very much to get the karyotype for the baby. So here's your placenta. Again, it becomes kind of a discrete organ somewhere around 14 weeks. So our trimesters, and again, there's a little wiggle room here. Is it the completion of the 12th week or the 13th week? Yeah, I would say potato. I tend to think of a trimester being somewhere in the neighborhood of around 13-ish weeks or so. I would never ask you to split hairs between, is 13 weeks first trimester or second trimester? I wouldn't go there. But I would expect you to be familiar that the baby's still developing at 8 weeks, right? But at 28 weeks, everything's done. It's just growing and getting bigger. 28 weeks is a critical point. 28 weeks tends to be the marker for third trimester. Okay. We'll go over this again. Trimesters come up a lot, and then weeks of gestation come up a lot as well too. So the placenta has a lot of functions that include metabolism, transport, endocrine functions. It produces a lot of hormones because remember, in pregnancy we want our hormones to be elevated. Because remember, I need that very thick, rich uterine lining to stay there. I need to have vasodilation, not vasoconstriction, because I need to get adequate circulation to help the baby get what the baby needs to have adequate fetal development. Now, in terms of what comes from the pregnancy, this is probably the most classic hormone that we think of is HCG. HCG. It is present in the patient's blood around day 8 to 10. and again, I would say after conception. And then urine around day 14. And so that's why when you miss a period, if you do a urine pregnancy test, it will show up positive. So let's talk a little bit about urine pregnancy tests. My guess is folks know a friend or someone that had a urine pregnancy test that was negative, but they actually were pregnant. And it may be that they actually did the pregnancy test too early, or they did it at the wrong time of day, and the amount of hormone was not concentrated enough in the urine to be able to flip the switch over. Again, they've changed somehow how they do pregnancy tests, so they're a little bit more specific in how they detect. But certainly if a urine pregnancy test comes up positive, then certainly there's a good likelihood that you're pregnant. I'm not 100%, but yes, I would go off the premise that you are pregnant if you have a positive urine pregnancy test. Now, you still could be pregnant with a negative urine pregnancy test, okay? And so let's say that I do a pregnancy test, and then 2 days later I do another one. Well, my HCG level should have doubled in that time. So again, if I've not had any bleeding or anything that makes me think my period is going to start, again, that pregnancy test at that time would be more confirmatory. There's no reason to do multiple urine pregnancy tests in the same day because the hormone needs time to double. Now, the other thing is, what should the level be? It depends. The key thing is that it doubles every 48 hours. So let's say you're an ER nurse. You have a patient who comes in and she's concerned that she's losing the baby. She's had some spotting after she had sex. She just found out she was pregnant last week. Typically what they will do is they'll do a beta HCG, they'll check her blood levels, they'll do an ultrasound to make sure that the pregnancy's in the uterus. They may not be able to see heart tones yet, and that's okay because it's so early in the pregnancy. But they usually will have follow-up with her that she will need to go see her doctor in 48 hours because they want to compare that beta HCG level in 2 days to the one in the ER. So as the ER nurse, you may not be able to reassure your patient about whether everything is okay or not, because again, very early, it's hard to tell. There's not, as you get further along in first trimester, we get heart tones, we can see the baby, we can measure the baby, it's easier to see that, okay? Now, with the placenta, I am gonna fall over this, I just know what's gonna happen. With the placenta, again, our primary hormones tend to be estrogen and progesterone. And so again, that's a theory that the placenta produces all these hormones to help support pregnancy. But in some people, the placenta starts to kind of get a little tired. And so that decline in the hormone is the trigger for when labor starts. And so that's a theory as to why some women who have preterm labor, they keep having it with subsequent pregnancies. It's their placentas just don't want to go the whole 40 weeks. Now, remember that progesterone is initially produced by the corpus luteum, which came from the Graafian follicle. And that happened because we had the rupture of the Graafian follicle, released the ova, and that was in the surge of LH. So we had the follicular phase and the luteal phase, okay? Now, this corpus luteum will disintegrate, but it sticks around until the placenta takes over. Corpus luteum produces progesterone. Progesterone is pro-pregnancy. So this is kind of the feedback loop, and I would know this. The corpus luteum makes progesterone. Progesterone supports the pregnancy. When you're pregnant, you make beta HCG. In the presence of beta HCG, the corpus luteum knows I need to keep making progesterone. The corpus luteum does not make beta HCG. The baby does, okay? The corpus luteum then says progesterone. So you need both things to work. Now, another hormone that kind of comes into play with the placenta is this HPL, human placental lactogen. It's also known as human chorionic somatotropin, okay? What's the key thing to know about this particular hormone? It antagonizes insulin. It fights insulin. Now, it comes into play around third trimester, right around 28 weeks or so. Why is that a big deal? It's because because that's when we screen women for gestational diabetes. Why in the world would I want to antagonize insulin? That seems kind of crazy. Well, you have to remember that little baby is super selfish. And so this hormone is produced so that the baby can get enough energy from mom to be able to grow. So it's designed to make sure that we don't conserve too much energy. That's what insulin does. We want energy to get to the baby because the baby needs it to grow and develop. It starts being produced around 20 weeks or so, but we're really concerned about it at 28 weeks because that's a big growth period for the baby. It's a critical time frame, but that's when we screen women for gestational diabetes, 28 weeks, which is the beginning of third trimester. So the other thing I will tell you about like weeks and trimesters, you have to remember that in the real world, like all patients cannot be seen exactly at 28 weeks, 0 days. So some people might be at the doctor's office and they're 27 weeks. They might go ahead and get their gestational diabetes screen at 27 weeks. Or maybe somebody's traveling, so they get it done at 29 weeks. So it's not always like to the day. It's kind of like when you pass meds. You can't pass meds at 9 o'clock to everybody. There is a little bit of wiggle room there. All right, fetal circulation. I'm going to give you what you need to know about fetal circulation. Now, it's planting the seed for, we have to know fetal circulation before we get to neonatal circulation, which kicks in after delivery. We're going to talk about normal, healthy things. When you get to peds land, you will talk about congenital heart defects that occur when things don't flip right from fetal circulation into neonatal circulation, okay? We are not going to talk about congenital heart defects significantly in this course. So right now, I'm a normal, healthy mom. I got a normal, healthy baby, and this is how circulation gets to the baby. So the first place I start through is the placenta, okay? So the placenta is located in the uterus, yes. Ideally, it's kind of up towards the fundus. Like, we don't want a low-lying placenta. We want it to be up higher. As blood comes through the placenta, it's coming from the placenta to the baby through the umbilical vein. The highest amount of oxygen is in the umbilical vein. You have one umbilical vein. You're going to go past this structure called the ductus venosus. The ductus venosus is going to bypass the fetal liver. That is intentional, because the fetal liver doesn't have a lot of responsibility in utero. The placenta does a lot of filtering and helps in terms of metabolism, so the liver's not really a big player in utero. But that's also why when the baby comes out, their liver has to kind of kick into gear, and it takes a little bit, so it's a little bit immature, and we get circulation kind of reestablished to the liver, but the liver sometimes takes a little time to kind of get into gear, and different metabolism needs to occur, so that's why babies sometimes have jaundice after they're born, okay? All right, so the ductus venosus is bypassing the liver, all right? Foramen ovale, it's an opening between the right atrium to the left atrium. So oxygenated blood is bypassing the liver, it's in the right atrium, and most of it, not all of it, is gonna go right to left. Why? It's because the lungs are not doing oxygenation for us in utero. You need a little bit, so it's not a one-way path. So what do I mean by that? Even in the ductus venosus, a little bit of circulation goes to the liver, but most of it's gonna pass that. Again, most of the blood is gonna go through the foramen ovale, but there's a little bit that's gonna go into the right ventricle and a little bit to the lungs, but not much, okay? So foramen ovale, right to left shunting. Ductus arteriosus, we're going from the pulmonary artery into the aorta. So we're bypassing the lungs. Very common heart defect to have a patent ductus arteriosus, okay? Again, most of the oxygenated blood is gonna go to the head, the neck, the heart, the brain. So my periphery really doesn't need a lot of oxygenated blood to help in terms of growth and development. So most of the oxygenated blood is shunted away. And so my systemic pressure in the baby, in the fetus, is low. My pulmonary pressure is high in the fetus, okay? The highest level of oxygenated blood is in the umbilical vein. Now, once blood has circulated through my baby and needs to go back to mom, it's gonna go by 2 umbilical arteries back to the placenta, okay? So what you guys will see in labor and delivery is a lot of times after delivery, they'll take a section of umbilical cord and they'll get cord gases through a section of that. And usually what they wanna do is get it from the umbilical arteries because that's the blood that's going from the baby back. So it gives you a picture of the baby's oxygenation status. If I draw blood from the vein, that doesn't really give me a good picture of the baby, okay? So it's a 3-vessel cord. You have 2 arteries and 1 vein. I think that's on your worksheet, okay? And so for those of you who are really fascinated by fetal circulation, I have a really nice Khan Academy video here for you, for your leisure time, which I know you have a lot. Okay. All right. The book talks about pre-embryonic stages. I don't really like that. Okay. What's the need to know? The need to know is this particular stage, embryonic stage, is our most vulnerable period for our little embryo. So if I have exposure to radiation, to chemicals, to cigarettes, to inadequate nutrition, alcohol, trauma, sexually transmitted infection, this is where it is most harmful. God bless you, to my growing baby, okay? Look at that. Isn't that cool? See his little feet, those eyes, little nose. So, okay. Now, the fetal stage is the end of the 8th week until birth. Now again, that's from conception. And so for me, as the labor and delivery nurse, I'm thinking more around the 10th week. I think again, when we're teaching patients, when we're talking to patients, the big thing we tend to say is the first trimester is really, again, when fetal development occurs. So in other words, after the first trimester, the fingers and toes are there, the heart's there, the kidneys are there, the bladder's there, even the genitalia are there. They're just not big enough yet to be able to distinguish yet on ultrasound. But that after that first trimester, everything's just growing and getting bigger, okay? So it's not like at 14 weeks, which is second trimester, the baby's missing a stomach, okay? The stomach is there. All the organs, everything is there. It just needs to grow and develop and mature. So you can see as this baby grows and gets bigger, it gets super crowded in there. Now, one of my pet peeves, because I've seen it more than once as a nurse, and it makes me very, very sad. It is an old wives' tale that the baby slows down in terms of movement as you get closer toward delivery. It's just that it's more crowded, so the character of the movement changes. So in some moms, you can actually see like the baby where they're moving and they're kind of turning and their whole stomach kind of changes shape during the 3rd trimester. But as we get closer to the end, there's just not as much room. But absolutely, your baby should move every day, and if you don't feel your baby move, you need to let your healthcare provider know. Okay. Now, back here, is the baby moving? Yep. You just can't feel it. Because you got these little tiny butts, right? Because they have to grow and move so that they get bigger. All right, you ready for your present? You don't want it? I'll keep it. You don't want it. I don't want to cause undue burden. You ready?
Yeah.
Okay.
Gift us, please. Thank you.
We need one more. Let's check and see. There's 2 extras, so. march of dimes, all right? So, this is so old school. I just kind of shake my head because we used to use pregnancy wheels like all the time, and a lot of old school folks still use pregnancy wheels. But most of this has been replaced by apps. So you can actually get an app that has all the same information. But what I would like for you to do, there's two sides. I don't have one because it's okay, I don't need one. But the first side, okay, where it has all the numbers and the dates. So if you look at the wheel, it says first day of last menstrual period. Does everybody see that on their card? And so you can match it up with the date. And then it has probable date of conception. And then notice as you kind of move across the clock or the wheel, so it says CRL, that's crown to rump length, and then BPD is biparietal diameter, okay? So that's talking about crown to rump, so it's measuring from head to tail, and then BPD is the measurement of the skull. And so that's how you kind of estimate, and then right in the middle of the wheel, you'll see that it says prenatal genetic risk assessment screening, CBS, okay? So that's not the drugstore, it's chorionic villi sampling, which is what I just talked about. Okay, chorionic villi sampling. Then you have early amnio, and then it says AFP. Okay, so early amnio is amniocentesis. Amniocentesis. So again, you'll notice it says early amnio, and if you look at the weeks, it's like 13, 14. So again, we don't do amnio in first trimester. It tends to be either really early second trimester or somewhere in that, you'll notice on here, it has it like between 15 and 21 weeks, okay? AFP is different than amniocentesis. AFP is a blood test on mom. And sometimes it's called the quad screen, and AFP just happens to be one of the markers of the quad screen, okay? All right, so we're gonna play a little bit. You are definitely going to have a question like this on the exam, all right? So we're gonna calculate due date, and we're gonna double check ourselves with our wheels, okay? So today is October 25th. Today is October 25th. So let's say that the first day of the last menstrual period was October 25th. So how do you use Nagel's rule to calculate? It is really important that you follow the steps, so don't try to cheat Nagel's rule. People try to do the opposite, like adding 3 months and doing different things. They get it wrong. So if you use the guidance, you'll be perfect, squared away. So you're gonna subtract 3 months. So September, August, July. I need to add 7 days. So if I add 7 to 25, I get 32. Well, there's not really 32 days in July, correct? So now it becomes August 1st of 2019. Now, with the LMP of today, you cannot use your wheel. Are you pregnant? No, because remember, if the first day of your last menstrual period is today, you haven't ovulated. You're gonna ovulate in about 2 more weeks. All right? So let's give you a different date. We're gonna practice and you're gonna check with your wheel. Let's say that the first day of your last menstrual period was May 1st of 2018. What's your due date? So calculate that. And then once you do it using Nagel's rule, I'm going to show you how to use your wheel. now, what you wanna do is take your little card, and you can either put the arrow on LMP, and then you hold it in place while you look around. I will tell you that pregnancy wheels often do not account for leap years, and they also may not have 31 days in some of the months, okay? So that's one of the reasons why when I have students do this question, if you're off by a day, because you can't remember if there's 30 or 31 days in August, I'm okay with that, because that's not really the need to know. The need to know here is if somebody says, I haven't had a period since May, trying to figure out when this person's gonna have a baby, okay? I don't know if you guys remember the little trick in grade school, that's how I remember my days, so it's like January, the knuckle here is 31, February's not, March has 31, April does not, May has 31, June does not, July, but August. So July and August both have 31. That's how I learned how to keep track of what has 30 or 31 days. But I think students think that's what this question's asking, like, are there 30 days in April or 31? That's not the question. The question is, can you calculate due date? And that's something you'll need in any area of nursing. It's not unique to OB. Because let's say you have somebody who doesn't know they're pregnant, and you're working with them, and you have to figure out, can this person go to x-ray or not, because she might be pregnant. And she might be able to still go to x-ray, but we just need to have some extra precautions there to protect the baby, okay? So the pregnancy wheel is a super fun toy. You do not need to have it for the exam. You are welcome to do with it what you like. You can take it to clinical, you can not take it to clinical. It's just another thing to kind of let you experiment with that. Did you come up with, was it the same or was it off a day? February 5th? Yeah. So, do we want to do another one? Okay, let's do another one. Plus or minus 5 days? Yeah. See, even March of Dimes gives you a window of error there. So, let's look at, so let's say, and I would never say, here's the due date, when was the last menstrual period? I would always give you the last menstrual period to figure out the due date, okay? What day did you guys start Excel? It's like May 7th? Oh, we just did that.
No, we started on the 17th.
Let's do January 31st of 2018. That's your LMP. When's your due date? So I'm going to subtract 3 months. But I need to add 7 days, right?